Thank you so much for the introduction and thank you for being here. I'll be manning the chat. I'll probably save most questions till the end unless there's something very urgent, then please make yourself known sooner than that. But just for the sake of flow. Okay, pass it back to you. Thank you.
All right, can you guys hear me okay and see my slide? Fantastic. So again, I'm Dr. Jennifer Mbuthia. I am board certified in pediatrics as well as allergy and clinical immunology. I work part-time at a bunch of different places, and I'm excited to talk to you guys this afternoon about food allergies and anaphylaxis. So no conflicts of interest. Any use of commercial product names is for the purpose of educational purposes only. And here are the learning objectives. Hopefully, at the end of this talk, there will just be something new that you have learned about pediatric food allergy and anaphylaxis. Um, so the first thing that I kind of want to go over is that food allergies are immunologic reactions that the body has to ingestion of a food. And although my focus today is going to be on IgE-mediated food allergies, there are also mixed or non-IgE-mediated food allergies that are very real, very much triggered by foods. A general pediatrician probably comes across things like food protein-induced enterocolitis, also called FPIES, or eosinophilic esophagitis. So those are considered true food allergies when a food is triggering these adverse reactions. And the diagnosis of these oftentimes is clinical. And when it comes to foods specifically, there are no standardized food tests to see what food is causing those kinds of reactions. So the only validated, studied testing for specific foods and a food allergy pertains to the IgE-mediated food allergy reactions. This is what allergists can do skin prick testing for. This is what blood testing is looking for. And that is what's going to be the focus of the rest of the talk. But I didn't want to ignore the fact that EOE and FPIES are food allergic reactions. Now, food allergy continues to be a growing concern, especially in the US and among parents. The overall prevalence of self-reported IgE-mediated food allergy in the US is approximately 7.6% in children and 10.8% in adults. Now, these are self-reported rates. So the data looking at food challenge confirmed rates are actually lower, only about 3 to 8% in children, and 1 to 3% in adults. Adolescents are considered the highest risk for having a fatal or near fatal food-related anaphylactic reaction. And that is largely due to risk-taking behavior, delayed or no use of epinephrine, as well as the potential for having coexisting asthma. So if a child has asthma, and a food allergy, those two are a very high risk situation for a more life-threatening or near fatal anaphylactic event with accidental exposure. Among adolescents, many times they may not have an actual memory of what their childhood reaction was. So as you are seeing adolescents, and the parent describes what the reaction was to you as their primary care provider, it's important just to reinforce to that adolescent. One of the things that I try to encourage is medical alert bracelets, especially in adolescents. And the way that I describe it to, these young adults is it's not for the people who know you well. It's not to tell your mom that you're allergic to peanut. It's to tell someone who doesn't know your medical history. And so teenagers, they're going out more independently without mom and dad there, and then they may leave to go to college. And so you're meeting people who don't know your medical history, and that's the value in medical alert tags. Now, interestingly, about 20% of US adults believe that they have a food allergy, but only half meet the clinical criteria consistent with an IgE-mediated food allergy. And then again, challenge confirmed data shows that it's probably closer to like 1 to 3%. But with that, it's very important to always ask maybe some additional details. If somebody says that they or their child is allergic to a food, ask for more details, ask what the reaction was, and then document it because many of the people who will report that they're allergic to, let's say, milk, it turns out that their symptoms are more consistent with lactose intolerance, which is not a food allergy. It is an enzyme deficiency, and it carries a very, very different risk as opposed to an IgE-mediated milk allergy. So reminders that food allergies are all around. Well, there's a requirement for food labeling in stores, restaurant menu labeling. We have just gone into the back to school season. So back to school forms will have things about food allergies. Oftentimes now when my children get invitations to birthday parties, there will be a question, please let us know if your child is attending and if they have a food allergy. And then also there's lots of things on social media. Some are good, some are not so good when it comes to food allergies. So this is something that is constantly around us. If you buy food, or if you go to restaurants, you are reminded about food allergies. And so it's important for primary care providers to understand them. So what does this mean for you as pediatric clinicians? It means a lot of parents are going to ask during those clinic visits or patient portal messages. You're going to get a lot of questions. You're going to get uploaded pictures and wondering, hey, is this rash? Is this spot? Is this hive? Is this a food allergy? So you guys are the ones who are going to be receiving the information first many times. While some patients may go to an urgent care, or we'll go to the emergency room. The messages that are received by pediatric clinicians or the questions during those visits represent a very large percentage of who is being asked first in terms of medical providers. So I want to start first by talking about anaphylaxis. And then we'll go into some details specific to some of the more common pediatric food allergies. So anaphylaxis is a potentially life-threatening allergic reaction. Now, fatal reactions are unpredictable, and statistically, they actually are very rare. But in children, food is the most common trigger of anaphylaxis. In adults, there are other things like medications or stinging insect venoms like bee stings, wasp stings. But in children, food is the most common trigger of anaphylaxis. So it's important for you to understand how to recognize it, how to treat it, and also what it's not. So when we think about anaphylaxis, the key parts of the immune system are going to be immunoglobulin E or IgE, as well as the mast cell. So mast cells reside in tissue. We have mast cells in our skin. All of us have mast cells. We also have mast cells in other parts, tissue parts. So we have mast cells in our airway. We have it in our gut. If you have a uterus, there are mast cells in the uterus. Now, at rest, our mast cells have immunoglobulin E already sitting in receptors. And that is why when they are bound and cross-link with their specific allergen, the reaction happens quickly because they're already sitting in the cell. And essentially, by cross-linking that peanut protein or that milk protein, the cells are going to spill their contents and degranulation happens quickly. This is different from other types of immunoglobulins. So immunoglobulin A or immunoglobulin G, IgG, these are not pre-positioned in the white blood cells. So that's why if you get exposed to an illness, it may take some time. You may have some early symptoms because that IgG has not yet bound and gotten rid of the virus that you got exposed to. But IgE is unique in that it's already pre-positioned and ready to activate the cell. Histamine is the primary chemical that causes the symptoms of anaphylaxis. It's a very vasoactive chemical upon release and also kind of causes the cascade in both the airway, the skin, and the gut. Now, in 2023, the anaphylaxis practice parameters, were updated. So about every 10 years, there are new practice parameters within different scopes of allergy, the rhinitis practice parameters, the asthma practice parameters, the urticaria practice parameters. So in 2023, it wasn't a full update. It was over everything, but there were some very key points that were updated in 2023. So the things that were specific to this 2023 update were updated diagnostic criteria that was more inclusive of recognition of delayed anaphylaxis from alpha-gal allergy. So alpha-gal is a type of anaphylactic reaction to mammalian meat that can occur at really any age. It tends to be older children and also adults, and it's tied to exposure to a specific type of tick that we do not have here in Hawaii, but you may read about or hear about alpha-gal. So they wanted to make sure it was reflected in the practice parameters. They also updated diagnostic criteria that were a little more age specific because infants and toddlers do not typically have full anaphylaxis as their first allergic reaction to exposure. Also, some of the symptoms that are seen in infants and toddlers can be different from what you might see in, let's say, a 5-year-old or a 10-year-old. So they wanted to make sure that all of this was included. Epinephrine prescribing was also discussed in the practice parameters. Some of it had to do with having epinephrine available in public spaces, just like having an AED available. They also said that when prompt epinephrine is used and symptoms resolve, that EMS activation may not be necessary. So this was a big shift from all previous practice parameters where we would tell patients, if you use epi, you have to go to the ER. This new recommendation stemmed from essentially COVID lockdown. So we were discouraging patients from going to an emergency room if they absolutely didn't have to. And what was found was that a lot of patients who had the need for epinephrine and their symptoms quickly resolved, and they still had another dose of epinephrine on hand, but they felt completely well, that they did fine. So going into the emergency room wasn't necessary. Now, oftentimes, comfort level is an important part of what we tell patients. So if I have a patient who is an older child or an adolescent, then I'll let the parents know that if your child needs the epinephrine, give it promptly. And as long as you have your second dose available and the initial symptoms have completely resolved and everybody feels fine, then it's okay to observe at home. Younger children, nonverbal or pre-verbal children, oftentimes I will still recommend going to the nearest emergency room. Whether it's by ambulance or not can vary depending on how quickly the ambulance can get to them versus they just go to the nearest emergency room. But part of that is because the younger the child, the more likely that that reaction has garnered a lot of anxiety in the parent, and they also may have delayed when they administered the epinephrine. So the additional layer of medical eyes on the child and then monitoring to check blood pressure, check vital signs, and basically give a blessing that, okay, when they are discharged from the ER, they are completely asymptomatic, I think is valuable for the parent. Now, anaphylaxis in the community setting, again, was in the new practice parameters, including schools and daycares. There are some recommendations in there about the lack of evidence that having like a nut-free school is beneficial. The data against having a complete ban of like peanuts in schools was in the updated practice parameter. There was also more data on the impact of beta blockers and ACE inhibitors on anaphylaxis severity, not as big of an issue for a pediatric population. They also address specifically mast cell disorders, mastocytosis, and how idiopathic anaphylaxis occurs. And then there was some updates on perioperative anaphylaxis, which is actually very uncommon in pediatric patients. So NIAID and FAN criteria for presumed anaphylaxis, essentially, you have at least one of the following. So within minutes to a few hours after a likely allergen exposure or likely anaphylaxis trigger, the patient fits into at least one of the following. So criteria number one or category number one is probably what we are most familiar with, what most ERs and urgent cares are most familiar with, which is that there are skin and or mucosal symptoms like urticaria, flushing, angioedema, to include angioedema of the tongue or uvula, and respiratory symptoms such as wheezing, cough, stridor, shortness of breath, or hypotension. So it's two organ system involvements here. The second bucket that would be presumed anaphylaxis is that you have two or more systems involved. And the reason why that's important is because skin is not always going to be part of the presentation. So they divide it into respiratory system, skin mucosal, hypotension or circulatory system, and then GI. So one of the things to keep in mind is that in order to have skin symptoms, you need to have skin perfusion. And especially in adults who have venom-induced anaphylaxis, they may have such quick hypotension that they don't perfuse the skin, but they have respiratory symptoms and hypotension. And so that's why that second bucket kind of leaves it a little more open to have two or more systems involved. And then the last bucket is hypotension after exposure to a known allergen is presumed to be anaphylaxis. So some other important things, like I said, that were in the updated criteria have to do with recognizing anaphylaxis in infants and toddlers. So the two infographics that I have are from the allergyasthmanetwork.org. They are meant to be administered or handed out to patients and families, but also can be given to schools so that they are more familiar with things to look for. So there was a publication a little over 10 years ago that discussed some of the unique aspects of anaphylaxis in children under the age of 2. And one of the key things is that vomiting, persistent and immediate vomiting, is oftentimes a symptom of anaphylaxis in young infants and toddlers, more so than it is a symptom in older children and adults. Now, what can get a little bit confusing is that vomiting can also be a symptom of FPIES, but FPIES symptoms are more delayed than anaphylaxis. So it goes through some things that people can look for, things like belly breathing, nasal flaring, a hoarse cry or croupy cough. And children tend to not have hypotension as much as adults do. So a lot of the focus is on things like their skin symptoms, their respiratory symptoms, and their behavior. These are those preverbal children, so you really have to go based on how they look. Now, there are some mild symptoms that may or may not be anaphylaxis, so they kind of subcategorize them. And those are things like signs of kind of nasal mucosal inflammation, sneezing, itching, some hiccups or spit up, arching of the back. But again, those milder symptoms can also be caused by many other things, such as reflux or just an infant having the hiccups. But the severe symptoms are kind of further defined and described for, again, parents or care providers, teachers, etc. Now, what is not part of the definition of anaphylaxis is also important to understand. Receipt of epinephrine does not mean that the patient had anaphylaxis. Also, the absence of epinephrine being administered does not mean that there wasn't anaphylaxis. And the reason why this is detailed in the practice parameters is that many patients with non-allergic urticaria or isolated angioedema, such as ACE inhibitor-induced angioedema or viral-triggered angioedema, will go to an ER and urgent care, and they'll receive epinephrine, and then they'll be given a prescription to take home. Or they won't receive epinephrine and they'll be given a prescription to take home. And neither of those situations are anaphylaxis. However, in the acute setting, when you have a patient and you're in the urgent care, or the emergency room, or in the clinic, you want to treat the life-threatening potential thing. So I don't fault providers who administer epinephrine because the clinical symptoms in front of them had them concerned about anaphylaxis. I say that allergists, we are often the Monday morning quarterback. We are often the detective. We are the ones that have more time to get more detail. I have had many patients who they get referred to me, and as I'm going through the medical history, it's usually adult patients. They'll be like, "Yeah," and then I went to the ER because I had anaphylactic shock, and I was like, "Well, hang on, tell me about what you had." And if I'm lucky, I have visibility of those ER records. The patient did not have shock; they had normal blood pressure. The patient also, based off of the broader picture and more history that I'm able to obtain, did not have anaphylaxis. However, in that ER setting, they treated that lip angioedema as anaphylaxis, and that was the discharge diagnosis. So that's what the patient is reporting that they have. But just because somebody got epinephrine in the ER, or they were given a prescription, that does not mean that they definitely had anaphylaxis. Another important thing to keep in mind is that many parents, patients, and clinicians withhold use of epinephrine even when it's available. And they do things like they do the triad. They'll give H1 blocker, H2 blocker, and steroids, and the patient still lives. And they'll just call it allergic reaction and discharge them home to have an EpiPen, that they pick up from the pharmacy. And upon getting more information and getting more history, the patient was actually having anaphylaxis. And so epinephrine should have been given, but wasn't. And they still were having anaphylaxis based on all of the clinical symptoms described. It's just more fortunate than anything else. The H2 blocker and the steroids did not save their life. The H1 blocker just made their hives better. So it's just one of those things where the most important part of suspecting anaphylaxis after that emergency room visit, so they're coming in for ER follow-up, is to have the details of the symptoms and the timing of the symptoms. That's the most important part. And then obviously, if those further raise suspicion, refer to an allergist for further history taking, and then also evaluation and testing. Ooh, okay. A little bit more about the patterns of anaphylaxis. The most common is uniphasic. Peaks within about an hour of allergen exposure, and then especially after treatment, and appropriate treatment resolves within a few hours. This is what most patients have. This is what most children have. There's also persistent anaphylaxis, and this is where the symptoms persist for several hours despite appropriate epinephrine treatment. This is rare, but very severe when it happens. So that patient who's having 2 to 3 days of hives, it's not anaphylaxis, and it's definitely not persistent anaphylaxis. Patients with true persistent anaphylaxis are in an ICU on an epinephrine drip oftentimes, and they continue to circle the drain. They are it's bad when it happens, but it can happen. So yeah, hives for several days, and then they come in to see you or they go to an urgent care. That's not anaphylaxis. Why? Because they passed the test of time. It's just hives. Then you can have refractory anaphylaxis, prolonged anaphylaxis symptoms despite aggressive treatment. Sometimes this can be due to the patient being on a beta blocker. So if you're treating anaphylaxis, and I usually say 2 doses of epi and they're still not responding. An important thing to check or have someone check for you is, are they on a beta blocker? Because if that's the case, then glucagon is the workaround in order to help resolve the symptoms. And then the last pattern is biphasic. And you have to meet 4 criteria in order to meet the definition of biphasic. Biphasic reactions are also very rare. And sometimes when I talk to residents that I work with over at Queens, and they'll tell me, hey, last night or earlier this week, like we admitted a patient who came into the ER and they had hives. So we treated them for anaphylaxis. We didn't give epi, but we admitted them. And I asked, why did you admit them? If they weren't severe enough to warrant epinephrine in the ER, why did you admit them? And they'll be like, well, because of concern of a biphasic reaction. So here's the thing. So criteria number 1, initial symptoms completely resolved after appropriate treatment. And then hours later, new or recurrent symptoms appear, but no new allergen exposure has occurred. The second phase oftentimes will happen within several hours. Usually it's about 8 hours. But biphasic reactions are associated with an initial very severe reaction and or delayed epinephrine administration. So if someone's initial presentation in the ER was not even severe enough for the ER team to administer epinephrine, they're not going to have a biphasic reaction because it might not even be anaphylaxis. But if you were worried about biphasic reactions, those are the patients where they probably got 2 doses of epinephrine. And that's why I usually recommend, if a patient requires 2 doses of epinephrine, they should be admitted, because now they go into a category where biphasic reactions may actually occur. Again, usually it happens, the average time is about 8 hours, or within the first 8 hours. It can happen beyond the 8-hour time frame, but if I want to say like more than 80 or 90% happen within the first 8 hours. I had more information here. Sorry about that. I've already gone over this because I forgot I already had this as the next slide. So this is hopefully helpful for those of you who are either working in the ER or are hospitalists. If the patient didn't even get epinephrine once, then it's probably they're not going to have a biphasic reaction. If they needed 2 doses, these are the kids where they need to be admitted for that observation. So having urticaria only that responds to those antihistamines, but recurs 8 to 12 hours later, is not a biphasic reaction. That's just hives coming back because the antihistamine starts to wear off and decline. Giving epinephrine and then needing to give a second dose 15 minutes later is also not a biphasic reaction. So those 2 doses given, 15 minutes apart, that's still the first phase treatment. But it does put them at a higher risk for biphasic reaction. 90% of biphasic reactions occur within 6 hours of initial reaction. Steroids and antihistamines do not prevent biphasic reactions. So despite allergists prescribing, we prescribe steroids and increase in their regular dose of antihistamines, or we'll prescribe cetirizine or fexofenadine for a couple of days after a real anaphylactic reaction. Why do we do it? Honestly, there's no true data to support doing it. We know it's not going to prevent biphasic reactions. It can sometimes make us feel a little better, but what I have seen clinically is when anaphylaxis occurs, which it happens relatively frequently in the setting of an allergy clinic, but that's because of what happens in an allergy clinic. We do food challenges, we do drug challenges, we give allergy shots. Anaphylaxis happens. With all of that widespread inflammatory reaction, there can be some lingering airway and skin symptoms for a couple of days after. So if a patient has asthma and they have anaphylaxis, their airway has been triggered. There's a little bit of lingering airway inflammation. Giving them a couple of days of steroids will hopefully prevent them from having a significant exacerbation of their asthma or symptomatic exacerbation of their asthma. The hives can kind of come a little bit because those mast cells in their skin have been triggered. They've released. And so the mast cells that are still lingering in the skin are a little bit twitchy, a little bit leaky. So giving some antihistamines can prevent the hives from recurring for the few days after. But the steroids and the antihistamines do not prevent biphasic reactions. So if patients are like, why am I on this? And it's like, oh, so you don't have a biphasic. Please don't tell patients that. It's really to try to control the aftershocks of the anaphylaxis, not the recurrence of the anaphylaxis. A little bit about anaphylaxis and serum tryptase. So I think that serum tryptase is an underappreciated, underutilized tool. So tryptase is a chemical that's released primarily from mast cells. When you have widespread mast cell and some basophil degranulation, serum tryptase levels go up. So this tryptase is mostly contained in mast cells, but basophils also have them. During anaphylaxis, mast cells release, but there also is basophil degranulation. So suddenly all the cells that contain tryptase are spilling. So the serum tryptase levels go up, but they're only elevated for about 4 hours maximum. If someone presents and you're not sure it's anaphylaxis, but you're going to treat it because I want you to treat for the life-threatening thing, it's helpful to have a serum tryptase, not for your management in the emergency room setting, not for your management in the ICU setting, but for the allergists, management and education and higher index of suspicion. So serum tryptase, the lab takes a couple of weeks to come back. So again, it's not going to change your clinical decision making in the moment, but I have seen cases within the last couple of years where the serum tryptase was actually a really important clue regarding the patient's symptoms. Several years ago, one of the pediatric residents, Aunt, who went on to now become an allergist. Aunt she was on night float and she sent me a text message being like, hey, when you wake up, I have a case and I'm a little worried that this patient who we admitted to the PICU is actually an anaphylaxis. And I happened to get up in the middle of the night to go use the bathroom and I see her text. So I text her back and I was like, tell me the symptoms. And I was like, get a serum tryptase. So she ordered a serum tryptase and the serum tryptase was markedly abnormal and high. Her gut was correct. So the resident had a suspicion. Now the tryptase level confirmed it later, but also her gut suspicion, I was like, yeah, this patient should be treated for anaphylaxis. There have been instances of perioperative anaphylaxis where because the patients are getting so many medications, the serum tryptase level is helpful because you're like, was the patient just having a drug reaction, an adverse drug reaction, or was it an allergic reaction? Important parts of that are, if the patient is anaphylactic to a certain drug or drug category, they need to strictly avoid. But again, this is something where it helps me as an allergist. The ideal window is 1 to 2 hours after or within the time frame of the event. I've gotten some calls from some of the pediatric hospitalists where a parent brought their child in, the child had hives and was admitted for presumed anaphylaxis, got discharged the next day. Then they come back 24 hours later and then they get readmitted because the hives and angioedema recurred. And so they get readmitted for recurring anaphylaxis. If you have a patient that falls into that category, please get a serum tryptase because by the time the child's seen by an allergist, the history is the history, the notes are the notes. Tryptase, though, is a nice objective piece of information. Capulani does not have inpatient allergy consultation capabilities. I have done the kind of side whisper to talk to some people about these cases, but I'm not privileged at Capulani. So your only option is to refer to an outpatient allergy clinic, which by the time that they're seen, serum tryptase is not going to be beneficial. But in the moment, the serum tryptase is going to be helpful for kind of helping to both identify and reassure that that patient may or may not have been having anaphylaxis. There are other reasons to get a serum tryptase, and that's mostly tied to mast cell disorders, such as mastocytosis or mast cell activation syndrome. But we're not talking about those. We're talking about anaphylaxis. Another important thing is epi first, epi fast. Epinephrine is the most effective treatment for anaphylaxis, full stop. It is first line treatment. It is also second line treatment if necessary and third line treatment. So it's going to act upon your alpha and beta adrenergic receptors. There is no absolute contraindication for the treatment of anaphylaxis with epinephrine. There are some conditions to be cautious of, such as early pregnancy, but delayed administration is associated with fatal or near fatal reactions. Do not rely on antihistamines, bronchodilators, or corticosteroids as first-line treatment. Epi first, epi fast. There is no cocktail. There is one drug and only one drug that is the standard in first-line therapy. So a lot of us are familiar with IM administration of epinephrine. I put this graphic up here just because there are a lot of different available injectable forms, and then there is also the intranasal form of epinephrine that is now available. Part of why I include this here is because, especially for the injectable forms, how long you press and hold for varies between the different manufacturers. It might just say 2 seconds, it might say 3 seconds, it might say 10 seconds. Just important for you to know because it does say it on the package, on the label. So when you're prescribing, sometimes there might be substitution. So if you tell the patient, oh, I'm going to prescribe this and you're going to hold and press for 10 seconds, but then they pick up something and it says hold and press for 3 seconds, it just those each individual manufacturer, how long they press and hold, there is some variation, but epinephrine is your friend. So now a little bit of talk about the 9 most common food allergens. I'm not going to go into detail about all of them, just some of the key ones. So sesame got added to the most common food allergens in the United States a couple years ago, but I created a graphic with Google AI and I was like, oh, this makes it look really pretty, but it really does go over the 9 most common food allergens. Finned fish is in a separate risk category from shellfish. So while we oftentimes will talk about seafood allergy, shellfish allergy is more common in the United States, but finned fish anaphylaxis is also up there in the top 9. So as it pertains to kind of younger pediatric age patients, I wanted to go over some of the high yield ones. So cow's milk protein, it's the first foreign protein introduced into an infant's diet. It is the most common allergen in young children, but that includes both your IgE and non-IgE mediated food allergies. So milk can cause food protein induced enterocolitis. So across all of the types of true immune mediated food reactions, cow's milk protein is the most common. Now here's the good news and why any child with even if you're like, this is a slam dunk, I know this kid's allergic to milk, I know that they had anaphylaxis, it is still beneficial to have them evaluated by an allergist because many IgE-mediated milk allergic children will tolerate baked milk before fully outgrowing their milk allergy. About 70 to 80% will tolerate baked milk first. And then a lot of these children will go on to outgrow their cow's milk protein allergy. And this is specific for the IgE-mediated cow's milk protein allergy. But these are the kinds of pieces of information and education that, a busy pediatrician, you may not be able to touch upon it while you're doing the kids, 18-month well visit, you're talking about a lot of other topics and issues related to growth, nutrition, safety. And answering lots and lots of questions on other issues. So these children should be evaluated and followed by an allergist because we can determine at what point is it safe to do a baked milk challenge or a uncooked milk challenge. And a lot of that depends on the child's age, how long it's been since their clinical reaction, any accidental exposures and what happened. So there's a lot of factors. We also factor in component testing as well. Another thing about cow's milk protein and food allergies, non-IgE mediated food allergies, are that about 50% of infants who have cow milk protein enterocolitis will also react to soy protein with the same or similar symptoms. Just something for you guys to know and be aware of. Next, I'm going to talk about chicken egg. So chicken egg is the most common IgE mediated food allergy in children. So milk protein is number one for all types of food allergy. Chicken egg is number one just for IgE mediated food allergy. Now the yolk is less allergenic than the egg white, which makes sense because the yolk is the fat. The white is the protein, and food allergy is developed against the protein component of the food allergen, of the food. Now, here's the thing. Uh, Yolk, white, yolk. I just like to kind of categorize it for parents as egg. I don't try to encourage them to just separate out the egg yolk and try to feed that to the child. I like to bake, and the egg yolks, when I separate them, there's still egg white on there. If parents ask, oh, can I just feed them egg yolk omelets or something? If a child has anaphylaxis to chicken egg, you want to avoid all eggs and then refer them to the allergist. Now, the good news about egg allergic children is that half of these children are going to appear to tolerate baked egg, so extensively heated egg. The reason why baked egg, baked milk is such a well-tolerated thing is because the baking process denatures that protein allergen. Um, so that's why baked oral challenges are often our first step. Now, children with a history of egg allergy, even if it's anaphylaxis, can still receive the influenza vaccine in any kind of setting that has appropriate age-based influenza vaccine, just because we're going to be going into flu season. Next, I'm going to talk a little bit about peanut. So peanut is the most common food allergen in children older than 4 years old. So you got egg number one in infants and toddlers, IgE mediated. Milk's number one for all types of food allergies in infants and children. Peanut is number one in those greater than 4 years old. So peanut products retain allergenicity despite highly refined things like pressing them. Now, another important thing, peanut is a legume. It's not a tree nut, but it has a nutty taste. Also, between 35 and 50% of people with a peanut allergy will also have an allergy to at least one tree nut. Walnut is number one in terms of the tree nuts. But you can have plenty of people who can eat all other kinds of what we call nut butters, and they can eat, walnuts, almond butter. They're just peanut allergic. But the reason why we have like a quote nut panel in terms of testing is because of the high association of tree nut allergy in those who are peanut allergic. Now, a little bit of hot off the press, but not hot off the press if you're an allergist, but it might be news to some of you guys. So there was an FDA approved product for oral immunotherapy for peanut allergy or OIT. It was called Palforzia. It has since been discontinued in the United States as of July 31st, 2026. The reason why I put that up there is because there is no longer an FDA approved commercial product for peanut oral immunotherapy. But here's the reason why. It's not because it wasn't safe. It's because it was super expensive. And instead of paying hundreds of dollars every month for the oral immunotherapy that is the manufactured product, you could go and purchase peanut protein powder and then follow protocols in terms of the measurement and grams of peanut protein per weight, and use that for pennies per month in terms of treatment. So oral immunotherapy is safe and can induce tolerance. And they just stopped making the product because most allergists stopped prescribing it because it was just a lot easier and a lot less expensive for families to buy peanut protein powder. Now, something regarding food allergies, food introduction. Early food introduction and food allergies is something that I'm sure all general pediatricians are familiar with because a little over a decade ago, there was a publication that came out, the Learning Early About Peanut Allergy or LEAP study. And what that study showed was that early introduction of peanut to atopic infants, basically infants who had eczema and or egg allergy, early introduction of peanuts reduced the risk of developing IgE-mediated peanut allergy, and the relative risk reduction was 80%. They introduced peanut and egg protein around 6 months, but not earlier than 4 months of age. Children who have, or infants with atopic dermatitis, especially moderate to severe atopic derm, actually should have peanut introduction closer to 4 months than that 6 month mark. And another thing that has evolved over the last decade, so when the LEAP study first came out and these guidelines were kind of first released, through both the AAP and NIAID, there was a stepwise or an algorithm that talked about doing serum or skin IgE testing for peanut first before the parent introduced it. That is no longer the recommendation within the world of allergists, not necessary to screen with a serum IgE test first, because a lot of these children with severe atopic dermatitis have super high IgE, and testing is going to be positive, and you don't want the testing to lead to avoidance of something when it is likely to be a false positive. So when they looked at the early introduction, one of the things that is also incredibly important is that the longer that introduction was delayed in terms of months of age, there was a loss of the potential protection. So what I mean by that is the children who received, there was a study in 2021 that found that for looking at introduction between 4 and 6 months versus 6 to 8 months versus older than 6 months. And this is all peanut introduction in high-risk infants, the ones with moderate to severe eczema. So for every month that peanut introduction was delayed, the odds of developing a peanut allergy increased 30%. So the graph from this article really shows that that 4 to 6 month window is so important. I get referrals for kids with atopic dermatitis, and they're, the kids like 10, 11, 12, 15 months old, and they still haven't introduced peanut yet. And the problem is that they haven't maximized the potential to fully tolerate. Will I still say, let's go ahead and introduce peanut? Absolutely. When I was a general pediatrician, we would have said, wait until they're 3 before introducing peanut. The LEAF study really turned that recommendation around 180 degrees, but early introduction between the ages of 4 and 6 months is so important in terms of how their immune system is pliable and able to adjust and not become allergic to peanut. A little bit more about outgrowing food allergies. And again, this is IgE mediated. So for milk, a little more than half will achieve full tolerance of milk, meaning they can drink a glass of milk by 5, and then close to 80% by the time they turn 16 years old. For egg, almost 90% achieve full tolerance, meaning they can eat scrambled eggs by 6 years old. So if they have baked egg tolerance by a year, it actually predicts they're going to have faster resolution. Children who have IgE-mediated soy allergy, about half will outgrow it by 7 years old, but that is one of the allergies that does tend to persist. Peanut, it's like the flip side. So like 80% of milk and egg children will outgrow that allergy, but usually about 20%, 15 to 20% of peanut allergic children are going to outgrow it. Generally, if they're going to outgrow the peanut allergy, it's usually identified by 6 years old. And the reason why, that's important is, I try to counsel parents, by the time they're 6, if they still have a super high IgE, their initial reaction was really severe, I'll even do peanut component testing. I'm like, look, we can recheck it again in a couple of years, but I think once you've hit 6, there is less and less of a likelihood that they will outgrow it. But all of these things are why involving the allergist early in management is so important. A little bit about diagnosing. I have about 9 minutes left. Number one is the clinical history. The clinical history is the absolute most important part of evaluating a food allergy. So the timing. Usually they're going to have symptoms within an hour of ingestion. Again, alpha-gal is a delayed type reaction, but alpha-gal is not commonly seen here in Hawaii, and it's very uncommon in young children, so infants and toddlers. You want to ask what was eaten, and then also what was new. So if a child was eating a peanut butter and jelly sandwich with a glass of milk, but they have milk every day, they eat bread or wheat every day, and the peanut was the only new thing, then in terms of what to avoid until they're evaluated, you only need to avoid the peanut. If you drink milk every day, that's actually protective from becoming allergic to it. If you eat cheese every day, if you have scrambled eggs a couple of times a week, you're not going to develop an IgE-mediated allergy to it. It's only what was new. And then also, what was the symptoms? How long did they last for? What was done to treat the symptoms? And then any other kind of medical issues at the time. Was there a viral illness? Was there also a fever at the time? Children with atopic dermatitis, we want to know, like, was there, there happened to be a flare of their eczema at the time. Allergy testing. There's two mainstays of testing. Both are looking for the same thing. Skin prick test, which is an immediate test on the skin looking for IgE, but they have to hold antihistamines for at least 5 days. They also have to have an area of pretty clear skin. Then you have serum IgE testing that's not impacted by antihistamines. The old school generation, which I don't even think you can do it anymore, is what people would commonly call RAS testing, allergosorbent testing, or RAS. The second generation, what we currently do is fluorescent enzyme immunoassays. It's not RAS. So if you call it RAS, you're referring to the old test, but still people talk about RAS testing, and I just know it means that you don't have a good friend who's an allergist, who was like, stop calling it RAS, you're embarrassing me, man. We can also do something called prick testing. So there might be some foods that the average allergy clinic isn't going to carry because purchasing that extract is low yield. You don't use it often enough to justify purchasing it. So you'll have the family bring in that food and then you do a fresh prick test. But allergy testing has great negative predictive value, but variable positive predictive value. The gold standard is an oral food challenge. Like I said, if the patient already eats the food regularly at home, or they have eaten the food since that ER visit or the urgent care visit, it means they're not allergic to the food. And then for the PCPs out there, if parents report reaction concerning for anaphylaxis, again, only eliminate the new food prior to referral. Don't tell them to remove all foods from their diet. Because testing alone does not diagnose food allergy. I wanted to still touch upon testing and timing. So testing for food allergies too soon after a reaction can lead to a false negative result. So if they were just in the ER yesterday and they're seeing you for follow-up today, don't order food allergy testing because you might have a false negative result. So if the clinical history is suspicious, usually we'll wait a few weeks before testing. By 4 weeks, you're not going to have false negative results if there's going to be a positive test. But what's even more important is the risk of false positives with food allergy blood testing and food panels. So atopic children have higher serum IgE levels at baseline. And if you do broad food panels, and I see this all the time, a lot of primary care doctors think that if a child has eczema, that you have to do food testing before food introduction. Please don't do that because you're going to have a very strong risk of a false positive result on testing. And then you're potentially going to tell them to avoid that food. So how labs report allergy tests have no meaning in the world of allergy. There is no such thing as a class 3 food allergy. Doesn't exist. So these classifications have zero meaning. Instead, we do have some guidelines on cutoffs and the positive predictive value of that cutoff. Some of it is based on the child's age, and then some of it is a more absolute. So food allergy interpretation takes into account all these factors, the clinical history, the food that is being tested, and the cutoff, also the patient's age, and if the patient is atopic. So if you don't know how to interpret food allergy testing results, then I really suggest not ordering it and instead just refer to an allergist. because you will also have patients who are sensitized but not allergic. And the risk of a false positive food allergy test in an infant with atopic dermatitis is 50 to 90%. A false positive, meaning they're not allergic to the food. It could be false positive because there was non-specific binding, or they might be sensitized but not allergic. And here's the potential danger of broad food testing. So, if a child was tolerating a food and now you take it out of the diet, and this is an atopic child, and they were tolerating the food, but now they're doing avoidance and they've eliminated the food, within a few months, they can then become allergic to the food because they're not seeing it, and the immune system now goes from sensitized to allergic. And I've seen this happen so often that as many times as I can, I try to provide information to pediatricians. Don't order broad food panel testing. I know it exists in DLS. Don't order it. Please don't order it. When in doubt, just refer to allergy. Let allergy determine what testing is indicated. I'm not going to go into detail about treatment of food allergies too much, but oral immunotherapy and sublingual immunotherapy can induce tolerance. There are food-specific protocols. These are very resource intensive, so that is why most of the private practice offices here in Hawaii, allergy offices, don't do oral immunotherapy. The reimbursement rate is low, and the resources that are taken are very high. But something that is something that I prescribe usually a couple times a year, because not everybody wants it, is omalizumab. It's a monoclonal antibody that binds IgE, and it downregulates the receptors on the mast cells. So it helps block the reaction. Now, OIT, SLIT, omalizumab, none of these cure food allergies, but they induce the ability to have what we call bite tolerance. So the patient still needs to avoid the food other than if they're on OIT or SLIT, their daily OIT. But this mitigates the risk of having anaphylaxis upon small exposures or accidental exposures. So some final pearls, and then I'll go to questions. So early introduction is important. Hives for days or weeks is not an allergic reaction. Epinephrine is the first line therapy. And please, 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 even if a parent asks, do not order broad food-based testing panels. So with that, I know I'm just at time, and we haven't even gotten into the multiple choice questions. So what we can do is launch the multiple choice, and I will go through. I think there's only one question in the chat.
Yeah, we actually we weren't able to create the poll for today, so we don't actually have the questions for everyone to pull through anyways. Everyone still gets CME. And I was gonna have us go through the questions, but maybe if you could just send out the answers and everyone can look through them in their own time. And then if you have a second to look at Dr. Maxim's question from
Yeah.
earlier.
Okay, so her question in the chat. After reviewing literature previously, I stopped using any histamine blockers or steroids in the rare anaphylaxis patients, and we admit, would you advise resuming use for all or only for patients who are asthmatic atopic? So definitely, if the patient has a history of asthma or a history suspicious for asthma, I would still do about 3 days of prednisone, and then usually 3 days, if they don't already take an antihistamine, 3 days of cetirizine. If they already take a daily antihistamine because they have allergic rhinitis, then just double the dose for 3 days. Like I said, it makes us feel better. So if you were to prescribe it, because allergists prescribe it, absolutely fine. The key thing is don't think that you're preventing biphasic reactions, and don't prescribe those drugs in the acute management phase of anaphylaxis.
Thank you. That's really helpful. So basically, we usually get them after the acute phase, right? If they've had a particularly severe reaction, that's why they get admitted for monitoring. And so in the past, or in the recent past, I've been giving nothing and just watching them, and they seem to do okay and not bounce back to my knowledge. But those kind of quality of life and like reducing risk interventions, it sounds like for anybody that's sort of a general wheezer, which is a lot of our kids, it would be good to do those things. But eczema, not necessarily. If they have no asthma history, it's only the asthma, not the other atopic condition.
Yeah. The other thing too is you can also, so in terms of like skin symptoms, you can imagine the parents probably have a heightened sense of anxiety. They brought the baby to the ER, the baby got epinephrine. It was scary.
Yeah.
So you can also provide some reassurance and just have them have Zyrtec on hand, and they can just administer it should the hives themselves recur. But
Mhm.
reassure them that if the baby's otherwise well, they don't have to come back to the emergency room for that. But yeah, definitely if the kid's got asthma, especially like, that inhaled corticosteroid kid who's not taking their inhaled corticosteroid and they had really bad wheezing with their asthma, I would absolutely give them 3 days of oral steroids because I want to try to calm that airway before they get readmitted for an asthma exacerbation.
That was such a really useful pearl. Thank you.
This entire talk has been full of so many useful pearls. I wish my brain could actually retain them all. I'm going to have to review this talk again
That's why you
to
have
help
the
remind myself. That's why we have it available.
look at the
Exactly.
slide.
I
Exactly.
actually personally have a few more questions, and I'm sure other people do too, but I also do want to be mindful of everyone's time as well, since it is already past 1:30. I guess maybe really quick, is there any reason to not use intranasal epinephrine in the outpatient setting? That seems like such a great solution to the whole fear of injections and also the varying duration with how each one is, administered and things like that. But is there any, I guess, contraindications?
So not really, unless someone has some sort of like nasal like anatomic issue. But here's the thing. If one of my children had a food allergy, at this point in time, I still feel comfortable. I would prefer epinephrine auto-injector. And here's part of the reason why. One, it's proven the test of time. So the studies on Neffy, it would be unethical for them to cause anaphylaxis and treat it. So the studies on Neffy are looking at bioavailability of the epinephrine in a patient who's not having anaphylaxis. Um, so I'm like, I mean, does it seem to work? Yes. But like, what if that kid's got a lot of goopy goop in the nose? I know it has a longer shelf life. It's smaller. It's not a needle, but I am more likely to, at this point in time, continue to want, again, this would be my own comfort level. I'm not afraid of giving a kid an injection. I'm not afraid of administering a needle. So part of it is if the parent, the parent's not going to use epinephrine, go ahead and give Neffy. But the studies, again, look great and it should work and it sounds like it works. Now, here's another anecdotal thing about Neffy. So you are doing intranasal epinephrine. And one of the things that is a fairly common complaint in patients who are verbal and can describe their symptoms is that they will have a few hours of nasal pain, facial pain, or if they have a history of migraines, it seems to trigger their migraines. When we give IM epi, you might be jittery for a couple of minutes, but there tends not to be localized soreness and pain. I mean, if you slammed it hard, yeah, it'll be sore. But with Neffy, there seems to be a decent number of people with a drug side effect. And it makes sense why they would have that side effect because it's causing vasoconstriction locally. Um, but there have been some parents who are like, gosh, I kind of just wish I had given the injection because now my child has pain. Now, granted, they're not having anaphylaxis and they're still alive, but now the kid's like complaining for several hours about the pain and they're trying to do symptomatic resolution of that. Um, so my personal preference is still to encourage use of epinephrine auto-injector, just because I think that there's a lot more consistency. We have a lot more experience as clinicians, but there will be patients. There are patients who are like, oh, can I get the intranasal as well? So in that instance, it is important just to make sure that the parent understands how to use it, the proper teaching, which there's videos, and in the allergy clinic, we can do that teaching. It's also a lot easier to hold down a toddler leg and inject it than to try to get their squirming little face because one little movement and your dose is on their cheek and not in the nose. So dose administration errors are also a factor.
Absolutely. Thank you so much. Thank you so much again. Okay, we're definitely over at this point, but I love that everyone hung around to hear the rest of these answers. So thank you so, so much again, everyone, for joining, and thank you for the wonderful talk with all the pearls. We will see you early September on the 2nd for our upcoming talk on how to navigate IEPs in schools. Thank you, everybody. See you then.